And I think we're a small enough group here. I'm hoping that maybe after we introduce ourselves, we could have you guys go around, just introduce yourself, your organization, and if there's anything you want to say, what you're hoping to get out of this session, because we really want to make it as interactive as possible. So I want to welcome you to the Addressing Legal, Regulatory, and Compliance Issues, which is the most scintillating workshop, clearly. We have some terrific panelists who are going to introduce themselves. I do want to also just acknowledge that we had a third panelist, Deb Espinal, MSJD, who's the Executive Director of Health Plan Policy Regulatory Advocacy at Kaiser Permanente. Unfortunately, kind of at the last minute, she couldn't be here today, but she was part of formulating the set of questions that we came up with, and so I think that was very helpful. So as I said, I'm Janet Pregler. My role here is, as Meg knows, a little bit twofold. One is I'm a primary care doctor. I work at a women's center. I've been a primary care doctor for almost 30 years. So just sort of naturally, I have in my practice women who identify as lesbian, bisexual, transgender, or queer. And I would say one of the things about being a primary care doctor that is really a privilege is that often you get to know those people well enough that they'll start to even give you feedback, tell you where you might have done something better or differently. And I think that's really driven me to try and understand, better the entire landscape. One of my roles at UCLA is as part of some of our policy committees, which I serve on with Meg. So just understanding how a lot of this drives what we do has also been important to me. So let me turn it over to Meg if you want to introduce yourself.
Hi, good morning everyone. My name is Margaret Armbruster. I'm an executive director at UCLA, and I oversee several areas. I oversee both of our emergency departments, trauma service and the observation service on the clinical side. And then on the administrative side, I oversee clinical regulatory affairs and policy and occupational health as well. I've been a nurse for actually 35 years, which was the time gone. So in many different fields, but the last 27 years at UCLA in various roles. And I think my interest in policy and how we apply policy came from as a staff nurse when things were kind of pulled together and put together and pushed on us with a lack of understanding of the repercussions, really not thoroughly understanding the patient populations we work with and those that work with all of our communities. So I think that's where my initial interest came in policy, and then it kind of spread out all over.
And I'm Amanda Goad. I direct the LGBTQ Gender and Reproductive Justice Project at the ACLU of Southern California, based in the Los Angeles office. We work on LGBTQ rights as well as reproductive justice, which I think is very closely intertwined through a combination of litigation, legislation, and other policy advocacy, and community engagement, educating folks about their rights, educating the regulated community about their obligations. A lot of our work in California these days has to do with implementation and enforcement, making sure the lovely protections and policies that exist on paper are actually bearing out in the way people experience the law.
Fantastic. Okay, so I'll just start in front if you wouldn't mind introducing yourself, the organization you're with, and if you want to say anything about what you're hoping to get out of today.
Okay, hi, my name is Audrey Lewis. I'm a community health worker for JWCH. And what I'm looking at today is rather trying to raise for my clients the rights the right for and how they get services. Fantastic.
Hi, good morning. My name is Diane Morales-Calconi. I'm a community outreach worker with JWCH. I work with the HEART program, and I also am here to learn more about getting rights for my clients.
And can you tell us a little bit, JWCH, what is that?
It's in the UCLA Health Center, and it's a community-based project located on Skid Row. We have several locations, but we work on Skid Row.
It's fantastic. Okay, so I'll go to you.
Hi, my name is Erica. I'm from, I'm with Planned Parenthood Los Angeles, and I work with youth, so middle school and high school. So I'm just, we implement our comprehensive sexual health education. So I want to learn, how I can work with schools to make sure that they're teaching that.
Hi, my name is Marielle. I'm with Planned Parenthood California Central Coast. I'm a community health educator, so I teach sex ed to middle and high school students. What was the question. So what I would like to get out of this is just, I don't feel like I'm fully familiar with all of the laws, as how some people aren't familiar with CHIA or California Healthy Youth Act. So it's, I would love to learn what the laws are so that I could help kind of bring awareness to it.
Good morning, everyone. My name is Angela. I work for Councilwoman Miriam Martinez, who represents City Council District 6. I'm trying to get policy ideas in which the councilwoman can be more active on queer issues.
Hey, Kimberly, I'm here with Pam. We're both from the LA County Department of Public Health Division of HIV/SD programs. And so primarily we focus on finding people who are HIV positive who are out of care. So maybe they haven't seen a doctor in about a year or so, sometimes more. Increasingly, we are working on more cases that are females. So it would be interesting to see, of course, how it intersects with things like policy. But traditionally, we've seen more males, of course, trans women, but we're seeing now a lot of unique sort of aspects to the female populations that we're serving, regardless of their sexual orientation, gender identity. And so we're here to kind of see what is it that we think is happening and what do we think is getting better, but all the stats are now saying things aren't getting better. How can you take that back into the concept? So.
I'm Pamela Mendoza with Kim. I also work for Division of HIV/AIDS programs. I'm a patient navigator. So in my role, I go into the community and try to navigate people back into care for their HIV services. And what I hope to gain is a better sensitivity and understanding of the population that we deal with often, which is lesbian and trans.
I am Stephanie. I am with Northeast Valley Health Corporation. I'm the health educator for the school-based division. So I am at middle schools, high schools, and community college level. Sex ed as well. Birth control counseling. Huge advocate for policy for youth and minor rights and all that. Every time I meet with a student who's just exercising their first rights, I inform them of everything that they're able to do here in California with their rights. And just big pressure for advocacy. That's why I'm here, to learn more about the laws just like yourself.
My name is Lily Wong, the Director of the Language and Cultural Resource Center at Rancho Los Amigos National Rehab Center, one of the LA County hospitals in Downey. So I'm also the LGBTQ advocacy office at Rancho also. Here I like to learn the implementation of LGBTQ programs and services and compliance strategies for the law, the latest law, and to be sharing with my hospital clinics.
Great, and Rancho is such a resource for disabled, or for women with disabilities. Yeah.
Good morning, Valerie Wagner, Clinic Director with ACLU Health and Wellness, and we're actually in the process of launching a lesbian and bisexual women's health initiative.
We'll go with you.
Hi, my name is Ayaka. I work at a LA LGBT center as a non-social worker for a integrated clinic care program. I would like to just keep myself informed with policies and laws so I can be a better advocate for my clients.
I'm Diana. I'm a staff attorney with the Cancer Legal Resource Center, it's a division of Disability Rights Data Center. And I'm just here to see if there's anything that can be useful to our callers that may be affected with cancer and also are part of the LGBT group.
Hi, I'm Allison Stoessel. I'm a professor and researcher at UC Santa Barbara, but I live in LA. And I train clinical school psychologist. And honestly, I'm just really trying to network. I'm back to LA after 15 years of living up north. And so just really trying to connect so that I can do community-driven research.
And a member of our organizing committee. So yes.
I'm sorry. Hi, so my name's Jen. I'm a fourth-year medical student at USC. I just found out yesterday that I matched into a residency in obstetrics and gynecology.
Yay! Jen, where are you going?
I don't know yet. Friday I find out.
Oh, Friday you find out where. Okay, they just told you you matched. Okay, good. You will have a job. Good.
Important part. But hopefully it's somewhere nearby. Yeah, I can still remember being in high school and looking up the policy on being able to excuse myself from classes to go get reproductive care. And I think that was really powerful. So I think understanding the policy is power. I'd love to be able to disseminate that knowledge to my patients and to take good care of them.
abreast of the latest and greatest policies, to be able to bring those back to our staff, and then also to inform, you know, when I go out to the schools and stuff, to work with staff there.
Hi, I'm Diana. I work for the County Department of Health Services. I work currently with compliance issues related to medical managed care. On my private side, I'm an attorney, and I work with the County Bar, represent HIV positive individuals pro bono work. So any information I can get, I take practice.
I'm Ariel Summer. I am a primary care physician working with Dr. Pregler in the Medical Center at UCLA. And like many primary care physicians, my knowledge of regulatory practices is some improvements. So I will just take any knowledge that anyone would like to give.
I'm work for LA County Public Health. I actually learned some information regarding the LGBT population. So when I work with the community, I can be side of awareness.
Hi, my name is Khadija. I'm with the Downtown Wellness Center. I'm here for professional development.
Hi, my name is Caroline. I work for Assemblymember Audrey Nazarian, Assembly District 46. And I'm here so I can relay the information I learned at this conference and the Assembly members on the health committee. So he really wants to know how to help this population.
Fantastic.
Hi, my name is Abby Corsall. I'm a senior attorney with the National Health Law Program. I do litigation and policy advocacy on healthcare issues, both locally here in California and nationally. I also work on our LGBTQ health project, and I've been feeling a little frustrated that we kind of lumped the whole LGBTQ community together, and so I'm interested in breaking it up and understanding what are the specific issues that LGBTQ women are facing and how we can do a better job of focusing on those.
Well, good morning, everyone. My name is Daniel Johnson. I'm a health educator at a clinic called South Central Family Health Center. So when I'm doing outreach, it's great to know all this information.
Hi, my name is AJ, and I work for Supervisor Super Fuel. And even though policy is my job, I'm pretty new at it. So I'm learning it as I do it. And so it's good for my own professional development to be at conferences like this, as well as to help inform my boss on her choices and to really help move forward meaningful reform.
Hi, my name is Olivia. I'm a doctoral student in public health, and I have I'm writing my dissertation on the policy impacts on the LGBT community. And what I want to do in my research, I just don't want to just publish and publish. I actually want to make a difference. And I realize that it's impossible.
Hi everyone, my name is Eileen. I'm part of the staff today, helping out with the conference. I'm also a master's in public health student at Coastal College, so I'd love to learn more about people issues in the community.
Great. All right, so how we decided to start out was for me to just ask a few questions that our group had formulated so the panel could respond, just to sort of start the discussion. And then once we're through those questions, really open it up to you for comments and questions. So the first is, to start the discussion, I'd like to address a few systematic issues before we talk about specifics of patient care, first relating to insurance coverage. So the first thing that we wanted to ask about is, we know that when employers negotiate coverage for employees, they may want to include or exclude specific things. As an example, an employer may say they don't want to cover assisted reproduction or gender-affirming surgery. Do employees in California have legal protection about what has to be covered? I'm going to throw that to the lawyer first.
So my answer to that is somewhere between yes and it's complicated. I think first of all, it is important to be clear that while employer-sponsored care is very important, that doesn't cover everybody. And the last set of data I saw for California was that about half of Californians were on an employer health plan, whether their own or a family member's. That leaves a lot of people who are participating in Medi-Cal or Medicare or an exchange plan or potentially uninsured. As to gender affirming care, I think Christy spoke to that some this morning. We have clear legal requirements in California that plans do need to cover gender affirming care consistent with how they would cover equivalent care for other health conditions. And that has been explicit since directives from the Department of Managed Healthcare and the Department of Insurance several years ago. There's also very clear obligation of coverage under Medi-Cal. Under Medicare, about 2014, when I was at the National ACLU, I was part of a huge team that worked on getting the previous bad national coverage determination that barred coverage of gender-affirming surgery lifted. But as with most things federal, it's kind of a mess now. There is no bar to coverage, but it is a struggle oftentimes for people on Medicare to find a provider who will actually provide the care they need, in part because the reimbursement rates are terrible. And then there's an exception to the mostly good news as to large employers that are self-insured, meaning that they might work with an insurance carrier as a third-party administrator, but they are providing the funding for the care themselves. In that situation, federal law preempts California insurance regulations, and the federal laws right now don't explicitly require coverage of things like gender-affirming care. So there are ways that people in that situation can advocate, but they don't have as clear legal protection. On the mental health side, I can just say briefly that the short answer is yes, that there are both federal and state laws that mandate parity of coverage between physical health care and mental health care, but that's really referring to sort of the parameters on insurance coverage, like what is the copay or how many visits per year. That doesn't go to the level of how easily can you access care when you need it. And it is a very common complaint that we hear, even here in Los Angeles, that people are having trouble either getting a prompt appointment with a mental health care provider at all through their insurance network, or in some cases the problem is getting access to a provider who is culturally competent to provide the kind of care that they need. And that, I think, is a particular concern for lesbian, bi, and trans women, where there are some particular needs, and there's a lot of data out there indicating that people sometimes, unfortunately, have negative experiences when they try to access care.
Meg, did you have any other comments about that?
I think that was a great synopsis of how complicated, it's yes and complicated. I think in my role, I deal with oftentimes those individuals who have not had such a great experience accessing care. And in that moment with that individual, we can help that situation, but then we have a good process in place where the next patient standing in front of us, whoever they may be, doesn't go through the same challenges. So that's where my role is, and that also, it continues to be challenging. You would expect that once you've fixed the system, given a scenario, that it shouldn't happen again, but unfortunately it does, and it's an ongoing challenge.
Yeah, and I just comment from the clinical side. Many big health organizations, including in LA County, including Kaiser, including UCLA, have struggled with the access issue for mental health. And I think many of you may have heard the recent ads by Kaiser about, we have mental health providers. And you think, well, why are they having an ad like that? It's because we struggle. So they're saying, we have this available for you. I was interested, and you may not have more information. Access to assisted reproduction has been a general women's health issue, certainly for some LGBTQ women, but also women who may identify in other ways. Any information about where we are with that, sort of legally in California, requirements, lack of requirements?
I can speak to that a little bit. It's not an issue that the ACLU has been in a leadership role on, but a number of healthcare providers and other advocates have been working on that. There are requirements in California that insurers need to cover infertility care, but it does not extend to IVF and some of the specific procedures that people need. And there was a state law that passed about 5 years ago that put an explicit non-discrimination requirement onto that. So you cannot be denied infertility care because of sexual orientation or various other identity characteristics. It is still being worked out whether that means what the advocates behind it wanted it to mean, which is that if you are a woman in a same-sex relationship, you don't need to prove a year of trying to get pregnant in order to access that care, which is absurd, but unfortunately some healthcare providers have required it.
Yes, so there were some comments people wanted to make. Yes.
I was wondering, under the definition of infertility care, like leading up to IVF, like what exactly do many providers consider inclusive of infertility care?
Great question, which I cannot personally answer.
Honestly, that is beyond my area of expertise in relation to fertility.
Right. So we're going to have a provider panel at noon that includes OBGYNs who would have expertise in this area. But I will say again, having worked for health plans with a wide range of women who might be seeking assisted reproductive services, there have in the past been requirements. Now again, I might fudge that by saying, well, did you think about it for a year? Did you, you might say pray on it for a year, whatever, but and that has been an attempt actually to limit costs. And I would say again, with my women's health hat on, we see this in all sorts of areas. So as an example, it's a struggle for me as a provider to get many of the Medicare pharmacy benefits to pay for vaginal estrogen for women who have menopausal vaginal issues. It is never a struggle for me to get these groups to pay for Viagra for men. Okay, so, and how do the insurers limit it? They don't say we don't pay for that, they just say, oh, your copay is $400. So again, I think to your point, that this gets so complicated. And I think we had another comment in the back.
I just wanted to follow up on Amanda's point to know that there are 2 bills pending in the state legislature right now that would address or expand infertility treatment, that both of them do explicitly require that the couple engage in opposite sex intercourse for 1 year before any treatment is covered, which is a huge concern for lesbian and bisexual women, of course. So we're working with the authors of those bills to try to make those more inclusive. We'll see where it goes.
Interesting. Okay. That's really weird that it was phrased that way in California, but again, we learn. So the second question I have is, a second systematic issue has to do with the growth of healthcare systems themselves. So again, as you all know, more and more physicians work for a healthcare system, which is great in many aspects, but then we're bound by the rules of those systems and there may be less choice for patients in some things. More and more patients in California are served by Dignity Health, the largest not-for-profit hospital provider in California. Dignity Health is a Catholic healthcare system. And again, full disclosure, my kids are in Catholic school, okay. Conforming to policies ultimately set by the Vatican. What are the legal and regulatory implications of a faith-based healthcare system, and what have been some implications for lesbians, bisexual women, and transgender people who were served either by choice, again, because maybe their doctor joins Dignity and they go there, or they heard Dignity's the best place to go for their care, or by happenstance, as we heard about this morning, that's where the ambulance took you in this system. So do you want to talk a little bit about that?
Sure. This too is complicated, and I want to be clear that it's not black and white, and I don't want to sound totally disparaging of Dignity Health or other Catholic health providers that are, in fact, major providers of care to the lesbian community and others in California. Dignity Health, through California Medical Center, is actually represented at this conference, and it's not the first time I've seen them doing something resembling LGBT outreach. But the ACLU has 2 lawsuits pending against Dignity right now. I am working on the one that is on behalf of a transgender man who disclosed shortly before his hysterectomy that the reason he was having it was as part of gender transition. The hospital in Sacramento abruptly canceled his surgery. He was fortunately able to get care a few days later at a different hospital, but that was extremely traumatic for him, and we believe that it was a violation of the public accommodations non-discrimination law that Christy spoke about this morning. The other case involves a woman in Reading who was trying to get a tubal ligation in conjunction with her cesarean section, and another Dignity hospital refused to provide that. And next week, we are going to be filing a 3rd lawsuit in this genre, not against Dignity, but against a different Catholic institution that had a religious reason for denying someone care. And as Janet said, Dignity Health was already the largest nonprofit health care provider in California and providing about 1 in 6 of the hospital beds. So in many communities, they are the only provider. They are in the process of merging with Catholic Healthcare Initiatives, which is going to further concentrate that power. There are a lot of issues with policies set by the Vatican dictating what care is available at those facilities. It's an issue as to gender-affirming care. It's an issue as to certain kinds of reproductive care and infertility care. It's an issue as to certain kinds of end-of-life care and decision-making. And there's also not a lot of understanding in the community of how all this works and what may or may not be available to you when you show up at a particular facility. So I think we have a lot of work to do, both on regulatory and government and community oversight of what kind of access people really have if their healthcare provider they're relying on is Catholic affiliated. We also have a lot of work to do in terms of information raising, and we have some very basic questions to work out as to whether a religious affiliation is a license to discriminate and to opt out of what are otherwise the non-discrimination requirements that apply to business establishments, including healthcare providers throughout California.
And Amanda, just to clarify, do you find that these sort of Vatican policies are sort of homogeneously, in other words, each Dignity League hospital you go to is thinking the same thing, or do you see that there's differences in how they interpret these policies that, you know, make it difficult to say exactly what's going to happen at a particular hospital?
Great question. There are specific ethical and religious directives from the Vatican that set forth their religious perspective on what healthcare is appropriate to provide. There are hospitals that adhere to those, and there are hospitals who don't within the Dignity chain and some of the other Catholic affiliated chains as well. And then there are sometimes interpretation questions as to whether a particular patient's care falls within the prohibition or not. So that adds to this sense of uncertainty and people showing up for a procedure, potentially not being able to get the care they needed at the end of the day, being routed, you know, to different facilities and having further delays in their treatment plan for reasons that may or may not be explained to them. It's a version of the access issue that it seems like we have an assumption in California that if your doctor recommends a particular form of healthcare and is willing to provide it, that you're going to be able to get that care. But the way this is working out is that in some facilities, some of the time, doctors are being overruled by hospital management, which is very concerning.
Meg, did you have any other comments about that?
I think it highlights an actual global problem in relation to policy, and not whether the policy is right or wrong. If it is implemented differently in different places, it is very, very confusing. And so, we should get the policy right the first time for the whole of the community, and it should be implemented the same way across the community. And that's an ongoing challenge externally in relation to policy making, and internally when we have our own hospital and healthcare policies across every system. So I think there's an opportunity for improvement.
And I should also add, the Attorney General's office in California has oversight authority regarding mergers of hospitals. So they weighed in regarding the recent Catholic Healthcare Initiative's Dignity merger, and there's another smaller one coming up involving Catholic entities, actually a Catholic entity merging with an Adventist entity in Northern California. And Attorney General Becerra's office regarding the Dignity CHI merger did come out with a decision conditionally approving the merger, and one of the conditions applied is an explicit requirement of LGBT non-discrimination, which is great, but it was already the law. And so we have a lot of work to do to sort of drill down on what that means and monitor the experiences that people are actually having as to what access is available.
And again, we like Jana said earlier, we respond to the experience people are having. We implement a policy, we put it in place, we think we did the right thing for all of the community, and then we'll respond to the not so great outcomes that people are having. And it's kind of backwards. We should be able to put our policies in place, have a thorough understanding, have really reached out to the community and had a lot of conversation, and make sure that what we do put out and we roll out is appropriate, and have ongoing feedback to make those changes in real time. And so until we actually do that, and it's a lot of work and it's a lot of energy, but in the long-term outcome, we'll have a community that's served better. So again, it goes back to the root of how we make our policies and those conversations. We all get an opportunity to comment on all of the new bills that are passed, all of the new public policy that is passed. Most people just don't comment. But if we did, we probably could start to change that fairly rapidly. Do you disagree?
Very much agree.
So that's why that's in your packet, right? You know, who to talk to,
Yeah.
right? Which I've learned from all the
Yes.
advocates here.
It's really super important to do that. And when I first stepped into the regulatory role, I really thought that it wouldn't count, particularly with, you know, Medicare and Medicaid. What we said wouldn't count, but it actually does. And I've seen it time and time again. If you can get a strong representation of the objection you have to certain policies, they'll change it. It will be changed. So it's really getting the groups together and en masse, making sure we serve our communities appropriately.
Right, and before we move from systems, Owen, I know I want to get your comment in the back. I mean, the other comment I'd make is, right, these issues as an example around dignity are very complicated. So I was actually asked to write a letter to Attorney General Becerra supporting the merger by someone who is completely committed to this community. Her daughter identifies as a lesbian, married to a woman. Her grandchild is their child, but yet she felt for overall service to her community, this had to happen because that's where the healthcare pieces were. So again, I think it gets really hard. You can't just say, oh, you know, just leave them alone. Yes, in the back.
The question is related to the merger, and in the same way that there are kind of like antitrust concerns, like in like corporate America, I mean, are those concerns looked at with hospital and healthcare mergers in the same way, with the same concerns in terms of sometimes having choice means that, you know, you can have a variety of policies so that people's access to certain things are not choked off? Is that something that is that at the Attorney General's office level they think about when they're trying to decide?
Short answer, yes. My understanding is that the antitrust and consumer protection bureaus of the AG's office are also involved in that process, although what I'm more familiar with, the advocates who were helping mobilize the community to learn about this and participate in commenting last year were focused on access to care for the LGBTQ community, access to reproductive care, and access to charity care, which of course is a queer women's issue among many other things, given what Christy was sharing this morning about poverty rates and the wage gap and the way that impacts households headed by two women. Even though it might not be as explicit, I think that is really critical to be paying attention to as a lesbian and bi women's health issue. But the short answer is yes, that process takes into account structural issues as well as more individual issues.
Yeah, and the only other comment I'd make is sometimes, again, in order to serve a community, the governmental entities can feel like they have very little choice. So part of the issue is, you know, running, as an example, a large hospital is not something that the government feels they can just step in and do. So if a hospital is financially failing, as is currently happening to a large hospital in Los Angeles County, there may be only so many entities that know how to do it that are willing to take it over. And I think that has been an issue for a lot of this consolidation, particularly in rural areas where basically choice is being taken away because the only option in terms of someone willing to take over the healthcare entity may be a faith-based organization. I don't know if that's something that you have, you know, seen in terms of how that is driven.
Absolutely, particularly in rural areas of the state where there's already a very small number of hospitals or clinics available, but as you just said, it can be an issue in urban communities too. I just think it's incredibly important that people understand the implications of having a nonprofit that is religiously affiliated take over and ask questions about what that is going to mean for access to care for particular procedures in particular communities. Because yes, the quantity of care available or the quantity of hospital beds is extremely important, but the nuances within that are important too.
Okay, so now before we open it up for general comments and questions, we wanted to address just 3 common clinical scenarios that we've all dealt with that have legal, regulatory compliance, and policy issues. So the first is, and this is something that I've heard, and I suspect a lot of you have too, I've heard from several single-sex couples or same-sex couples that I know that when they were with their newborn in labor and delivery, the staff would enter the room And they might see, as an example, two women of sort of a similar age, and they might say, well, who's the mother, or in some cases, who's the real mother? How would each of you handle a concern like that if it was brought to you about this situation? So Meg, I'm going to start with you.
That is something that happened very recently to a very good friend of, two very good friends of mine who went to an area that I supervise with their newborn who was having some respiratory difficulties, and that exact scenario happened. So it was pretty devastating to me, because here they are with their brand new baby, it's all excited, the baby's sick, and I thought that my staff would take great care of them, and in fact they took great physical care of the baby. But in addressing who was the real mommy, that was completely inappropriate, and I thought they knew better. So I listened, of course, to my friend and her wife, and we had a lot of talking and consoling over that, and then I went directly to my staff. I went directly to my staff that were involved in that, and of course they were devastated. It was really out of not knowing what to say and how to address that they made this pretty huge mistake. And so that group of people who had made the mistake, we were able to have them sit down with the parents and have a conversation. And it was so enlightening for them that we were able to educate the rest of our staff and spend some time educating the rest of our staff so that the same mistake doesn't happen again. And that's the key. I think nobody, particularly in healthcare, wants to, all right, let me just change that, most people in healthcare, right, really do not want to be offensive in any way. They just lack the skill of communication in that scenario. And so my role is to give them that skill and give them those tools. And so that's how I would respond again in the same situation.
I think this is a great illustration of how things like adopting a suite of wonderful inclusion and diversity policies and getting certified by HRC as 100% on the Healthcare Equity Index and all of that is necessary but not sufficient. You're not really doing very much good unless and until those policies also involve training for all the staff on what they mean in a safe space, interactive kind of way where people can work through what they find confusing or off-putting about the policy, and then some form of accountability when something doesn't work out. I can also mention sort of related scenarios that have crossed my desk recently include hospitals not understanding or honoring that under current California law, when you are filling out a birth certificate for a newborn, parents can put themselves down as mother or father or parent, and it is the parent's choice which of those words to use. And also with older children, it also comes up as to who is in a position to consent to pediatric care for the child. In a two-mom household, it may well not be a biological mom who's taking the child in, but that doesn't mean they can't consent to health care.
And I think, just back to your comment, you can have as many policies as you like. You can have great policies that can be perfectly written. If they're not implemented appropriately and those they pertain to are not aware of them, you don't have them.
So here's one that I would say occurs in my practice. Again, I'm a primary care doctor. I've been in practice for 30 years, so many of my patients are older. And I would say this scenario comes up often with older patients. Despite a lot of attention to the subject, some same-sex partners are denied access to their loved one in intensive care unit situations. When the staff says the patient's so sick, we really need to limit this, only legal spouses are allowed. So how should this sort of situation be approached?
The situation is completely inappropriate, and whoever we designate as our next of kin or the person we want to be with us when we're sick, that really is the patient's decision. And so the behavior needs to stop immediately, and we would intercede immediately, and we absolutely have to ask the patient, who do you want at your bedside? And that's how we would handle the situation. I think we, luckily in our environment, we have done a lot of work in relation to that, and the staff are very, very aware that it's the patient is the center of care, and then make those decisions. And that's the only way to have an appropriate decision across all of our communities that we serve, that the patient is the center of care and they make those decisions when they can. It's challenging when they can't. Again though, we would intercede on behalf of the patient on behalf of the spouse, the next of kin, the family member that lives with the patient or is the closest to the patient.
And I would just add, I think it's incredibly important that we do community outreach and get people to understand the importance of not only executing a healthcare directive, but having it on file with your healthcare providers and ideally carrying a copy with you on a flash drive or something like that, because situations do come up where the person cannot express their wishes, and sometimes that's when it matters the most, who is able to visit or make a healthcare decision.
Yeah, and I just comment, I work, as Meg knows, quite a bit on the electronic health record at UCLA and how we manage that. And I think there's two things. One was, I was surprised to learn, and I actually learned this a few years ago from a Kaiser Permanente representative, that in the state of California, your legal spouse is not legally mandated to be the decision maker if no one is listed. So in many states in the country, if you don't have an advance directive, legally your legal spouse is the decision maker. In California, that's not so. So again, very important that people have this documented. One of the ways, this is, you know, as a doctor, right, the doctors are like, oh, electronic health record, right, typing. But this is something where I think it's really helpful. So one of the things that we're doing at UCLA is implementing a module called Advanced Care Planning Module, where people can easily identify who they would want to make decisions if they can't. And anybody can put information in there, but only a healthcare provider can actually activate it and say, you're unable to make decisions, so now we're going to have such and so person do it. But the other great thing about that and about our ability to put the full advance directive in is then it's electronically with us, which means if you're in another state, you know, you can contact us. It is electronic. So again, it's not perfect, but I think for a lot of people, it's an advance in terms of just having that, you know, in a space for people.
We also have in our electronic health record, we have something called Getting to Know You. And it's really, again, about our individual patient-centered care, so that in the privacy of the patient's room, that relationship with the nurse and the patient, they can get to know you and who you really are. And we can keep records of, you know, how you prefer to be addressed, who your next of kin is, and all the really usual, sometimes difficult questions or private things you wouldn't want maybe other family members to know. We can keep that in the health record and private between the care team and the patient. And so that's been super effective in some of these challenging situations.
So we had a couple comments. Jen, did you want to?
Yeah, I wanted to ask specifically, I'd love to hear more about the what you described as, you know, activating that sort of additional information about who could make those decisions, because my understanding of competency in, you know, determining that is it's on a decision by decision basis. So how do you make sure, you know, because delirium, they can be in and out, how do you manage that?
That's a good question. So as you well know as a physician, at the end of the day, in most circumstances, it's the physician team deciding that, you know, you lack competency at this moment in time, and so we are going to work with someone else that hopefully that you have identified to make decisions for you. I would say, again, you really get to the core of it. That's fantastic. So one of the questions came up is, who might say in that module that an individual permanently lacks competency to make decisions? Again, it's fairly common, particularly among older people in the hospital, that there might be a few days where they are delirious, they can't understand these issues. But what about saying it's permanent? And again, the issue is only physicians can say that it's permanent, and then there needs to be documentation. And often in those cases, particularly for younger patients, there will also be legal documentation of an assessment of competency. And again, the clearest thing for people who aren't clinicians is, you may have a young person who is very limited neurologically because of a birth issue or something like that, where it would be clearly documented who would make decisions because this person is unable to verbally communicate or that sort of thing. And Ari, you want to make a comment?
So this is actually just a plug to everyone here who's not a physician to help us with this, because I give my patients literally ad nauseum our advanced healthcare directive, and when I get it back, I go on and on, like, oh my God, you brought it back to me? They never bring it back. And I remind them, and it just never happens. And I think it's because it's not something you do in the doctor's office, in your crazy, squished in visit, where you're doing 30 other things. and you just forget about it, even if you have a physical piece of paper. So for people who work in the community, if you can really say how important this is, I think that would help a lot.
Right, because again, as a physician, I work in the hospital too. You never want to be in a situation where someone can't speak for themselves and you don't know who they want to speak for themselves, right? I think that's, that is a difficult situation. So the final one before we open it up, and I was so reflecting on this. So this scenario was actually suggested by the panel, and then I did my basic life support recertification, my CPR. Did you do that this year too, Lauren? No, you're last year. And so we talked about how one of the steps to pass the test is that you have to rip the person's clothes off to do CPR. So here's the scenario. A difficult situation that Meg related to us is that of people who identify as transgender whose clothing is removed in emergency situations in the emergency department without discussion or permission. So doctors and other healthcare providers, EMTs and so forth, might say that this type of protocol might be necessary in extreme situations, like the patient has died and needs to be revived, or the patient has been shot or stabbed or had severe trauma. So Meg, how did we handle this situation, and what are your reflections on that?
We had a situation where, in fact, we do this a lot in the emergency department. We see a lot of emergency cases. I think in this particular case, we were somewhat overzealous because we take everybody's clothes off and we want to get a good look at you and make sure what's going on. When it's a trauma and it's really emergent, yes, we have to do that. But I think even in those circumstances, if you're not immediately dying, we can say, Meg, I need to take off your clothes. Yes, there are people here, but it's private. We're all medical professionals. We can say that. But I think that we forget we have the time to do that. And again, it was because of our patients' feedback. And I have to say that even though it's a complaint, when people pick up the phone and say, look, I was in your emergency department, the care was great, but this is what happened. I'm alive, but this is what happened. And that was really not satisfactory. I'm really grateful and they're really brave to do that because a lot of people are put off. Because we do make changes given those conversations. And it really is letting our clinicians know, yeah, there are dire situations that we have to deal with. We have to deal with that situation. But in the case where the patient's awake and talking, we can have that conversation. And it may be a very quick conversation. We have to do this right now. But it's better than just not doing it at all and taking somebody's clothes off and there they are exposed to multiple people. It's way better in that moment to know that it's okay to have that conversation, to take that pause, and that's how we deal with those things.
So Meg, how did you develop that? Did you get the clinicians together to discuss this? Because it's obviously, it's physicians, but it's also obviously the RNs and so forth.
It's nurses and technicians, and because, in a situation where you're called for a trauma or you're called for a STEMI or a code blue, your mind is right there to either start CPR or do we know what the mechanism of injury is or how sick the patient is to get to that, to understand what's really going on. But there's also, sometimes, more often than not, there's a time to say, hi, I'm Meg, I'm your nurse, and this is what's going to happen. And yes, we do have to take your clothes off. Yes, we are going to have to do this. And it's kind of interesting because the patient that reached out to have conversation with me was a transgender patient, but we have often had some of our homeless patients say to us, please don't cut my jeans off. They're the only pair I've got. Everything does translate across all of our patient populations. And then you have to think twice, do we really need to take the scissors to people's clothes? So again, we want to really serve all of our communities as individuals all of the time. And so we're very grateful when people reach out and share their experiences, even when they're not so great, because we will make change.
Any other comments you had, or has that been an issue that's come up legally?
Not that precisely. This is reminding me, I represented a transgender woman who had a very rough experience as an inpatient in an Orange County hospital. And I have to be a little vague because it resulted in a confidential settlement. But the way that problem started, she'd been taken to that hospital in acute circumstances by ambulance. She had asked in the ambulance, could you please take me to X hospital because I know they're trans friendly. And the paramedics said, no, we think your life is in danger. We must take you to the closest one. So she's already in a state of sort of agitation about this. And it was when she needed help using the restroom that the personnel in the ER learned that her anatomy was different from what they were expecting. And that sort of started this cascade of other problems that were very stressful for her and compounded her ability to recover from her health problem. And so I think what Meg is suggesting about listening to feedback about what the procedure should be is incredibly important, but also that training aspect. And there are going to be situations where private information, either about a trans patient or in a variety of other circumstances, gets shared. And the important thing is that everyone who's in the room out of the healthcare team is able to handle that appropriately and respectfully, and it's not going to impact how they care for the patient going forward.
Okay, thank you. So I want to open it up for comments, questions, things you think we missed that you want to talk about. Yeah, Jen.
So I guess this is sort of a trans question, but I'm aware of a lot of surgeons, or not a lot, but there's a few very good surgeons in California who do surgeries for trans individuals. However, that for a lot of patients involves flying to those individuals, and then they come home and they have complications. And so I'm a little interested in the process of understanding, the requirement for primary care to take care of those individuals and manage those complications, and what kinds of things can we keep in mind for advocating for those individuals? Because a lot of them can't handle a plane ticket back to their surgeon.
Yeah, I think, and again, that may be a good question for the lunchtime panel because they're clinicians, but I would just make the following comment. Again, I think this is an issue that has broader implications for many patients, right? So as an example, we do a liver transplant at UCLA, and then the patient goes home to a rural part of California. And I would say as a clinician, there's a bit of a balance there. I mean, yes, we want local physicians to take responsibility for everything they can do, but sometimes things are also, out of their knowledge base, really. And so I'm hopeful that some of the efforts in telemedicine, which is something that we're really working on at UCLA, will be a way that we may be able to address this in terms of saying, we get it that you haven't dealt with this, but we may be able to do this via telemedicine so that the patient doesn't have to travel, as you said, and can't afford it.
It seems, from what I've heard at least, that it's almost like a form of discrimination because they're complications that could actually be handled as long as they weren't from the specific procedure that was described. And so it seems almost like people, I hear this a lot, I guess, from trans patients that they say, well, my physician said, oh, I don't know, I have no idea. It relates to trans care, so I'm not touching it. And so I wonder, are there policies in place to say, no, you are capable of this?
Right, as I say, I don't think there's policies that regulate, saying as an example, as an internist, do I have to do a procedure that I say I'm not comfortable with. But again, I would say, I think for physicians, there's two sides to that coin. One may be that seriously they're like, I don't want to deal with transgender people. But it also may be that they honestly feel that they don't have that skill set. And then how can we better connect them with people who do and can help, grow that. So I honestly think it can be, both.
Yeah, I was going to say kind of the same thing. I'm more familiar with the problem of people trying to get access to surgical care, and as you were saying, there are a few specialists in gender-affirming care. They are scattered around the country, often very expensive places, and sort of historically people felt they had to travel to get care, which is difficult for a number of reasons. It would be great if more surgeons were comfortable and felt competent and would just make their services available for gender-affirming procedures, but it's tough to push that point. And at the same time, I don't necessarily want to be trying to force a surgeon to do something that they're actually not comfortable with, that they're not going to deliver in a culturally competent way. And meanwhile, there's all this other advocacy going on behalf of trans people who need to go out of network to get care. And if you start making the argument that any general surgeon is competent to do this, it complicates that. So it's tricky. And it sounds like what you're talking about is more of a need for primary care physicians, ER physicians, other folks to feel comfortable just responding to basic needs that come up, which, as Christy was sharing, it is unfortunately still pretty common for people to experience friction as soon as they disclose that the kind of care they need is in any way related to gender transition, even if it's not surgery or something complex.
Yeah, and I just say something you said earlier really resonated, which we've seen in care of women with disabilities, and actually very relevant in OBGYN, which is reimbursement. So if the reimbursement for Medicare for gender-affirming surgery does not cover the cost of the rent and the nurse, and does not even pay for the physician, even people who may want to learn to do that and want to do it, they say, I can't work this out. And it's been a similar issue with OBGYN, that when you're paid for a 15-minute visit, and care for some women with disabilities might take an hour to perform a Pap test, as an example. People who otherwise might be really open to that just look at that calculus and say, I can't make that hand. And if I get known as the person who does this, then I even can't make it more. So again, I'm not defending it, but I think it's something that operates. And so that policy advocacy for fair reimbursement for these things is also, I think, key. One last question or comment. Yes?
You touched on something very important. It's not so much about passing policy, it's the enforcement aspect of it. And I wanted to know, in your ideal world, short of course money solves everything, right, with the training, how do you see that being enforced? Do you see that as the responsibility of the government to come into the hospitals and provide that training and awareness of policy? Or?
Oh heavens, no. I see it as a responsibility of everybody in healthcare. I think that the most successful policies that are implemented are those that we look at when we exercise something called active daily management, when we actually spend time with the people providing care. And we observe how they provide care, and we can give in-time feedback. We can ask them for their feedback on policies, and we implemented this, we gave you some education, you're working with it for a couple of weeks now, how's that going? And having that ongoing conversation with our providers, nursing staff, physician staff, and clerical staff, and our patients. And that is the way you have successfully or not implemented a policy. And even if you feel like it's successfully implemented on the clinician side, maybe the patients feel like it isn't, and vice versa. And again, it's exhausting, but we have to do that if we want to be successful with this. So.
Yeah, and I'd say if you look at big change in healthcare, and an example of that is the adoption of the electronic health record. Okay, electronic health records have existed since I started practice 30 years ago. But the implementation of those prior to around 2012, 2013 was very small. I don't remember the exact number, but let's just say it was 10%. Now it's over 95%. What changed? From the government, a carrot and a stick. Okay, so the government said, we'll give you some money to implement these, and if you don't, we're going to stop paying you so well. Suddenly, all these health systems, including UCLA, said, oh, I think we can do this electronic health record now. So I think if there's a carrot and a stick approach for these things, I think health systems can respond. And then I think to Meg's point, what we do is so arcane, at that micro level. I think it really has to be the individual practitioners. It has to be the medical assistant telling us, how is a medical assistant best going to do this within the framework of understanding what it is we're trying to do. That would be.
Yeah, I think so. I think you have to have buy-in from the people providing the service and those who are receiving the service, and understanding of that before before it's successful.